is the global epidemic. And I have to give you an apology to begin with, because the data from the new IDF Atlas is under embargo until the 14th World Diabetes Day. So I can tell you some of the highlights of it, but not any detail. And I'll try to do that and talk about diabetes in general and the IDF this year, the centenary of insulin discovery. Now I'm trying to move my slide on. It doesn't want to move. Yes, it does. There we are. So you all know that currently I'm president of the International Diabetes Federation. And of course, I've been and visited your wonderful country many times, including several times to Ahmedabad, and probably almost every state. So the IDF, of course, has more than 240 member associations from across 170 territories across the world. And one of our major concerns, of course, is the huge and growing problem of diabetes across the world. And one of our main contributions to diabetes, every time we have a World Diabetes meeting, is the Diabetes Atlas, where we collect and disseminate data, and now are the global authority for the prevalence of diabetes across the world. Let me just remind you of what the data were 2 years ago when they were launched in Busan at the IDF's meeting in December 2019. At that time, it was calculated, and this would be a gross underestimate, as you will appreciate, there were 463 million adults with diabetes across the world. And the projected increase you see here. The biggest increase, sadly, it was projected to be in your region, Southeast Asia, but particularly the Middle East and North Africa, the MENA region, and Sub-Saharan Africa. 2 years ago, 1 in 11 adults across the world had diabetes. 1 in 2 were undiagnosed. And 3 of 4 people with diabetes, especially undiagnosed, live in the low and middle income countries across the world. A huge chunk of global health expenditure goes on diabetes. And as you know, diabetes affects particularly the older population, but no age is spared, including, of course, children, particularly with type 1. But increasingly across the globe, we're seeing children with type 2 diabetes, probably due to westernization and altered lifestyle, etc. So the global epidemic, 2019, was estimated that 500 million people had diabetes. In my country, about 6%, or nearly 5 million. Abdul Basit from Karachi published a study a few years ago showing 1 in 4 adults has diabetes in Pakistan. And of course, it's very high in Middle East countries. Last weekend, I was delighted to be lecturing at a real meeting in person at the Arab Association for the Study of Diabetes in Cairo. The most recent accurate data from Egypt, published 5 years ago, showed that they then had the 9th highest prevalence globally, and the prevalence had tripled in the 2 decades from just at the end of the last century. There was an increase in type 1 and type 2, as seen in other countries. The prevalence of diabetes in Egypt was thought to be around just under 16% and is now much higher. Pakistan, I've already told you. In 2018, a paper published there, the study was done in 2017, 26.4% had diabetes of adults, more than 1 in 4. But also we've seen increases in pediatric diabetes in type 1 and type 2 in children. And here's one example from the United States. Let me now share with you some of the highlights of the data that will be presented, and I hope all of you will be registered for our IDF Complications Congress to be held at the beginning of next month, just in a few weeks from now. We've got very low registration rates for low and middle income countries, and the first day of this meeting will be dedicated to presenting all the data this year from our Diabetes Atlas. There will be 2 symposia on that, and a symposia in between on the celebration of the discovery of insulin 100 years ago. But the data estimated this year show that the rise has been 75 million up to 537 million cases worldwide. Now, 1 in 10 adults across the world has type 2 diabetes, and 44% of these are estimated to be undiagnosed. The prediction for 2045, I showed you on a slide a few slides ago, 700 million, now 783 million. And sadly, this figure will climb. It may be as high as 1 billion people by 2045. The global cost of diabetes care this year, $966 billion US dollars. Some more data here from our atlas, as I said, to be published at the IDF meeting next month. The rise in global cases between 2019 and 2021 this year has been 16%. 2 years ago, we predicted that this figure would be achieved by 2030, and here we are with that figure today. These are very depressing statistics. Sadly, these data will get worse. We all know the huge impact that the COVID-19 pandemic has had on diabetes, people going undiagnosed, people not attending for follow-ups, rightly frightened to come to hospital clinics because hospital equals people with COVID, diabetes plus COVID equals bad outcome. 6.7 million, it has been estimated, people have died in this year due to diabetes and its complications. This accounts for more than 10% of deaths across the world from all causes. So there's no doubt that diabetes is now an epidemic of unprecedented magnitude. It was a few years ago that Paul Zimmet, who you all know from Melbourne, who was famous in the 1980s and 90s for touring the Polynesian islands and showing how common diabetes was in these people, indigenous people who had been westernized. He talks about diabetes and obesity as the diabesity epidemic and says that this might be the biggest epidemic in human history. And this was 4 years ago, and now the figures are even worse. An underrated global public health issue. And we cannot simply focus on traditional factors such as genes and lifestyle. We also need to look at and focus on maternal and child health. So we have a global war against diabetes. As you all know, in any conflict, there will be many battles, and these need to be fought for diabetes, not only locally and nationally, but globally, regionally. And the battle is even harder now because of COVID-19, and the gradual swing of interest towards non-communicable diseases may have been partially reversed because of this viral pandemic. So the messages for governments and the world at large have not changed. We cannot afford to ignore diabetes as the human and economic costs are too great. A huge chunk of national healthcare budgets is spent on diabetes, and of course a large part of this is due to the late complications, particularly those in my area of interest, lower limb complications and renal disease, especially end-stage renal failure. Ronald Marr wrote this paper a few years ago talking about the global burden and the rise of type 2 diabetes in Southeast Asia, predicted to be 150% over these years. And he described this as a rising global public health tsunami. No doubt he was right. So let me ask you a question. Is diabetes really the cancer of the 21st century? I'm not criticizing our colleagues in cancer, not at all. We should learn from them. They have shown us that screening of high-risk groups is effective, true for diabetes. Long-term remission and even cures are possible, true for diabetes. Increased public awareness has been effective. Sadly, this isn't necessarily true yet for diabetes. Now, our colleagues in cancer have used fear arousal. People are frightened of cancer. So this has stimulated public engagement. I'm not advocating this for diabetes. And this course has been effective in raising large sums of money for research. So we need to learn from our friends and colleagues working in the area of cancer. Let me give you two case history to demonstrate. Here's a male in his 60s, asymptomatic, but had routine screening and was found to have a high prostate-specific antigen of 33. Underwent a transperineal biopsy. Prostate cancer was confirmed. Scans showed no metastases. What's the treatment? Hormonal therapy, followed by brachytherapy, then external radiotherapy. Outlook, cure. Well, what do people say? I've got prostate cancer. Oh, that's terrible. I hope you're going to be all right. Oh dear, I hope your family is not too upset, and so on. Well, I can tell you, ladies and gentlemen, that was me. That's me. 3 years ago, I was found to have a high PSA of 33. I went through all this, and my colleagues, even medical colleagues, said, oh my God, that's terrible. But look at the next slide. This could be me too. This could have been me. And by the way, cured. PSA now 1. This could have been me. A male in his 60s, routine screening, found to have glucose in the urine. Further tests confirmed type 2 diabetes. Examination shows evidence of some neuropathy and some proteinuria. Nothing significant, but it's there. Diabetes treated with medication. Outlook, no cure. Significantly increased mortality rate, even with very early complications, perhaps increased by 30%. What do people say? Oh, never mind, it's just a touch of sugar. My grandmother had it. She was alive till 90s. We need to change this view of diabetes. This is a patient with diabetes writing in the Sunday Times a couple of years ago. This was a patient who had had an amputation. And he wrote, I thought cancer was serious. Heart disease is definitely serious. But diabetes didn't feel serious at all. And now I've only got one leg. Preventable diabetes, preventable complications, preventable amputation. Very sad. So we need to change the global approach to diabetes care and screening. And the 21st century diabetology should be prevention, primary prevention by screening high-risk populations, especially those with a high risk family history of diabetes, obesity, sedentary lifestyle, gestational diabetes, other conditions, and so on. There's no economic benefit to screening randomly the whole population. Target high-risk groups. And then go for good, up-to-date blood glucose control that's accessible and consistent, and screening for the complications regularly, because the complications are all silent in their early stages. Retinopathy can present with a sudden retinal bleed. Nephropathy can present with nephrotic syndrome or end-stage renal disease. Neuropathy can present with a foot ulcer, and earlier this week I saw just one such patient. So we need to move forward. So the second half of this talk, I'll talk about World Diabetes Day, which for the last year to 2023. And you know that World Diabetes Day falls upon the birth date of Banting, one of the discoveries of insulin. Last year, we focused on the diabetes nurse. Nurses make a difference. And across the world, in my country, in the UK, and working also in the USA, the diabetes nurse, the nurse educator, is an equal member of the team. They're so important in delivering diabetes control and education and so on. Let's promote the role of the nurse, not only 2020, but forever. But this year, of course, it's 100 years later this month that the first dog, they say called Rosemary, although some dispute that, was firstly injected with insulin successfully by Banting and Best there, Banting and Best. And Professor MacLeod was the professor of physiology originally from Aberdeen, who gave the space and supported the research. And of course, Colin was the biochemist who synthesized insulin. So we're celebrating 100 years since the discovery of insulin, and it was February 1922 that the first child, Leonard Thompson, was successfully injected with insulin, a life-saving treatment. But we want to not only to celebrate the discovery of insulin, but to talk about access to diabetes care. So it's a century of diabetes innovation, and probably the greatest discovery of the 20th century was this, the discovery of insulin. Here's one of the first vials of insulin. As you know, before the discovery and widespread availability of insulin, type 1 diabetes was a death sentence. Patients went on the Allen diet, which was virtually no carbohydrates, 400 calories a day, and either died of starvation, or disease, infection, or ketoacidosis. So what we're advocating for is not only the earlier and accurate diagnosis of insulin, but access to insulin, a system for delivery, monitoring, and lifelong education and support. It's a story as old as humankind, as you know, is diabetes, at least as old as record keeping. And I was, as I said, in Cairo last weekend, lecturing there. And of course, it was Egypt, where Ebers, an Egyptologist from Germany, discovered the papyrus that now names his name, although I don't think our friends in Cairo and Egypt are too happy with that. But this was the description of a condition where there was passing of too much urine. And of course, early work came from India too. The first documented test for, I won't try to pronounce this, but honey in the urine. Shashruta, a Hindu physician, did a lot of work in India. But then it was the Greek physician Aristeas of Cappadocia who described diabetes as the melting down of flesh and limbs into urine. And Cappadocia, by the way, is now in modern Turkey. But perhaps the closest there was Oskar Minkowski, who was born in Kaunas, Lithuania, and then went to Prussia, to Königsberg, now Kaliningrad in part of Russia, and later to Strasbourg, where he worked with von Mehring, and he was the one to show that removal of the pancreas from an animal led to diabetes. But of course, it was these four, and you see here Banting and Best. I always tell my medical students there's hope for them, because Best was a medical student when he got the Nobel Prize, and here's Collip and MacLeod. So insulin, early insulin, and here's the definition: a hormone produced in the pancreas by the islets of Langerhans, which regulates the amount of glucose in the blood. By the way, Langerhans discovered the islands in the pancreas, now named after him, the islets of Langerhans, when he was a medical student in Berlin. So again, there's hope for our students. But this was a breakthrough, there's no doubt, seeing the torsos of people dying of starvation or disease, infection, ketoacidosis, transformed after the injection, regular injection of insulin. So this was a breakthrough that changed everything. But initially, insulin changed everything only for a privileged few. Now, R.D. Lawrence, you might be interested in medical history, he was the first person in insulin, one of the first to receive insulin. Now, this is in his later years, but I can tell you the story of Lawrence, and he was training to be a surgeon at King's College Hospital in London. And he developed thirst and polyuria, and he knew this is diabetes. It's a death sentence. And it was indeed. In 1921, it was a death sentence. So he said, I want to enjoy the year or two I've got left to live. So I'm not going to stay in England. I'm going to go and work as a primary care physician in Florence, in Italy, on the Allen diet. And he did just that. I gave the R.D. Lawrence lecture, amazingly, more than 30 years ago, and I read the notes that he wrote. And he got a telegram in 1922, later on in 22, saying, come back, to a friend of his from King's College Hospital, from a friend. We have insulin. It seems to work. Lawrence wrote in his notes, this is probably quackery, but I'll go back. He arrived back seriously ill and was one of the early people to receive insulin. And he changed his mind. He got well again on soluble insulin 4 times a day in those days. He gave up doing surgery. He saw the light. He became a diabetologist. And he lived until 1968 and was the senior physician at King's College Hospital in London. He founded the British Diabetic Association, the British Diabetic Association. He had type 1 diabetes. And the co-founder was the science fiction writer H.G. Wells, who had type 2 diabetes. So that's the British Diabetic Association, a bit of medical history. So, of course, Banting and MacLeod were the ones offered the, granted and given the Nobel Prize for Physiology and Medicine in 1923. But Banting said, I'm going to share my half with Best, and MacLeod shared his half with Collip. So 4 laureates. After that, of course, there was a ramping up of insulin production, and there have been great changes over the centuries since then. So 1920s, insulin, diabetes education, first commercial insulin, longer-acting insulins, the addition of protamine or zinc, PZI or PZI as they call it in America. In fact, people thought they could get away with one shot of soluble in PZI or soluble in lente or soluble and isophane, Hagedorn insulin, if you like, MPH. But we know now that that wasn't so good. Then we have more modern insulin, semi-lente, lente, velocillin, insulatard, you'll remember. Then we move forward to human insulin, synthetic human insulin. And today, of course, we have all sorts of rapid-acting and very long-acting insulins. We have inhaled insulin, Afrezza, in America and so on. In terms of devices, the glass syringes were used for many years. My first diabetic clinic was in 1977. Glass syringes, sulfonylureas and metformin, the only tablets we had, and no home blood glucose monitoring and no glycated hemoglobin. Then we had glycated hemoglobin, then insulin pumps. This is the first artificial pancreas, slightly big for what we see these days. Then we got onto pumps, pens, and now we have all the modern devices, continuous glucose monitoring, closing the loop, and so on. So huge progress has been made. But please remember, before the discovery of insulin and widespread insulin, as I've told you already, the diagnosis of type 1 diabetes was a death sentence. Sadly, 100 years later, in many parts of the world, it still is, because not everybody has access to insulin. The most important feature of World Diabetes Year this year is not only the celebrating the discovery of insulin, but advocating access to insulin, not only insulin, other injectables, oral hypoglycemics, SGLT2s, etc., to anybody that needs them for diabetes care wherever they are in the world. So we place World Diabetes Day in the 2021 and the centenary of celebration under a broader multi-year program dedicated to access to diabetes care. So this is a 3-year theme, as I've said, to promote access to these technologies and education that ensure affordable and quality management for diabetes and its complications, and advocate these should be supported by prevention programs and screening, primary screening, preventing it developing, secondary screening. People who've got diabetes, screen for the complications. Tertiary screening, if someone has neuropathy, let's try and prevent a foot ulcer, and so on. This is what we're talking about this year. So let me end with a few quotes from the book of Ecclesiasticus in the Bible. It states, before you speak, learn. But interestingly, before you fall ill, take care of your health. And this is a pivotal message for people at risk of diabetes. We can prevent it. If you have diabetes, take care of your health and prevent complications. So I'll finish with a reminder that, as I said at the beginning, that this year we have a virtual diabetes congress in the first week of December, the 6th to the 11th of December. Registration is open. We have a huge program with more than 110 speakers. We've got a lot of abstract presentations. The first day, as I said, will be the insulin centenary and IDF Atlas. So all the figures that I couldn't share with you today will be presented 4 weeks from now at this meeting. Also, we have streams on the complications, foot and neuropathy, retinopathy and nephropathy, and cardiovascular and vascular complications. But we also have a stream on COVID-19 and diabetes, which of course we've learned so much over the last 18 months. So with those words, I will finish by saying Dhanyavad, and I hope you have a most enjoyable RSSDI. And I really look forward to seeing my many friends over there in your country in the not too distant future in person, rather than this rather impersonal lecturing to you where all I can see is myself. That's the last thing I want to see, I can assure you. So have a good meeting, and thank you for your attention.